In cardiac arrest, how do we ventilate a patient? How many times a minute? 10. How much volume? Third to half the bag. Do we manipulate how we ventilate a patient in cardiac arrest to achieve a specific end tidal CO2? Or do we just keep it strong, keep it steady, and let the end tidal CO2 be whatever it is? What do you think? Option 2, we do not manipulate, we don't change. If we were to teach people, okay, if the end tidal CO2 is low in cardiac arrest, bag them slow and try and keep it between 35 and 45. Would we have been able to have the entire discussion we just had about perfusion thresholds and considerations to increase that? No, because you just would artificially inflate the end tidal CO2 by hypoventilating the patient, even though you don't do anything to change the perfusion or metabolic box. Okay? Or if we were to teach someone, if it's high, hyperventilate them. Well, number one, you're hyperventilating a patient, which is a big no-no. Number two, what does ROSC do to your end tidal CO2? Spikes it. So now we're trying to breathe off ROSC and we miss ROSC. Okay? The only way you can get insight into the metabolic and the perfusion box is if you keep the respirations constant. Okay, because if they're constant, nothing changes, but the end tidal CO2 changes, we know it's not a breathing thing that changes it, it's something further downstream. And then we can have the discussions we've been having. Plus, you never want to find yourself in a spot where you have to hyperventilate your patient at arrest. Does that make sense? Keep it super consistent, 10 times a minute, third to half the bag. The reason I'm repeating this over and over again is this patient is the exact opposite. The closed head injury ICP patient, we change how we ventilate a patient to achieve a specific range. So we got to make sure we don't get them confused. If they're dead and they have no perfusion themselves, strict 10, third to half the bag. If it's ICP, closed head injury, this patient needs a specific range. And we're going to understand that right now. What happens when you hyperventilate to the blood vessels in the brain? Do they constrict or vasodilate? They constrict. Okay? So the way the brain regulates blood flow is it looks at PaCO2. Looks at the blood CO2. And what was the first slide? The whole capnography comes from the smoke idea of the Greeks. Because CO2 is a byproduct of what? Fire. Human fire, metabolism. So the brain is a very smart organ, it knows this. So if it sees normal or high, particularly higher CO2 levels, it says, hey, there's activity in that part of the brain, I'm going to vasodilate and get it blood to support that. Because the liver is an organ that gets 100% blood flow all the time. But if the brain, because it does so much, got 100% blood flow all the time, you'd have this huge noggin, and we'd have been probably eaten by some prehistoric dinosaur a long time ago. Okay? So the brain has evolved, created, designed, whatever you believe, to strictly regulate blood flow. Only do the parts that show activity by looking at CO2 levels. Higher CO2 levels dilate. Lower CO2 levels, no activity, constrict. Control the flow. Okay? When you hyperventilate, what does it do to your CO2 levels? Lowers them. So what's the brain think as far as what blood flow is needed? No activity, no blood, I don't need as much blood flow, constrict. So that's why hyperventilation constricts blood vessels in the brain, because it lowers the CO2 and the brain thinks there's no activity, and so it doesn't need as much blood flow. Okay? And this is not a new mechanism. They knew this. That's why we used to hyperventilate the crap out of ICP patients, because we were trying to constrict to control the bleeding. Because bleeding into a closed cranial vault, not good, right? It can eventually, in the extreme cases, can push part of the brain out the bottom. Okay? So we want to have a little bit of a constriction. But what they found is the constriction was so profound, it was like putting a tourniquet on the neck, it was doing more harm than good. So now it's like, okay, we can't crazy hyperventilate patients unless some systems still have you hyperventilate and Cushing's triad when they're herniating, because they're going to die anyway, so you might as well try and do something. Okay? But for the most part, we got to be careful about hyperventilating and being part of the problem. But we also want to still provide some bleeding control, so we need a little bit of constriction. So then the question is, what are the thresholds? And end tidal CO2 became the perfect tool to help answer this question, because that's what the brain's looking. Well, it's looking at PaCO2, but end-tidal CO2 is a result of PaCO2. Okay, they're fairly close, unless there's a major, lung pathology, trauma, or medical. For the most part, PaCO2, and in shock, really, really sick patients can have a gap, but for the most part, they run fairly close to each other. So the first study that was done was on pigs to just figure out, okay, at what end-tidal CO2 threshold then is a constriction in the brain detrimental, and at what level is a complete dilation, uncontrolled bleeding? And they found it was 30 and 50. They actually physically directly measured the pig's cerebral perfusion by putting probes in their brain, hyperventilated, and they found once they hyperventilated the pig's end-tidal CO2 below 30, the constriction was so great, cerebral perfusion was virtually nothing. It was like 4. Okay? It was critically low, more harm than good. They underventilated the pig and let their end-tidal CO2 climb above 50. That was dilation and uncontrolled bleeding. But 30 to 50 doesn't help us much, because that's outside the normal range of end-tidal CO2 itself. So then he did a human study. What I like about this study is this is a pre-hospital study. So this was done at the doors to the ER. So the paramedic team, EMTs would say, I'm bringing in an ICP patient. Researcher would meet them or they may have done it retroly. I'm not sure if it was active or retro. But they looked at what's the arriving end-tidal CO2 of the ICP patient over several months. And then they tracked all the patients that died versus lived. I think they defined lived as at least returning to part-time work. They qualified lived beyond just sucking on a straw. So the patients that lived had an average initial end-tidal CO2 of 30.8. And then the patients that died had an average initial end-tidal CO2 of 26.3. So that's pretty narrow. Out of that was born the permissive hypocapnic approach, which most medical directors in the country agree with. But you need to discuss it with your medical director because it's not in your protocol. Okay? So a little bit of low end-tidal CO2, just slightly below normal for a little bit of constriction, a little bit of bleeding control, but not so much constriction that you're part of the problem. Okay? So you manipulate how you breathe for a patient in ICP to achieve 30 to 35. And be careful, now technically, you can manipulate volume or rate. Okay? High pressures in the chest increase ICP, because the pressure in the chest is what the blood coming out of the brain has to overcome to get back into the chest. So try to probably keep in a perfect world, if you can keep your tidal volume fairly normal and achieve this by rate, that would be ideal. But there is that's arguable and really up to clinician discretion. Okay? Now discuss this with your medical director, because technically this is the full spectrum that they have. So Dr. Daniel Davis, medical director in Southern California who did this research, his medics are 35 to 40. Okay? Some neurosurgeons are 40 to 50. Most medical directors who don't have a dog in the fight, or this kind of research is not really their passion, they'll just go with the general consensus of 30 to 35. So discuss it with your director. So in cardiac arrest, you ventilate consistently or you change it? In cardiac arrest, consistently. In cardiac arrest, consistently, 10 times a minute, third to half the bat. In ICP patients, you change it to achieve a specific range. All right, so these are cardiac arrest patients. Tell me what you would do, just really quick. I just want to make sure we got everything I threw at you in a very short amount of time. I mean, it probably feels like a year. Yep. Make no waveform, pull the tube, assume the worst, esophageal intubation, start over. Where do we want end-tidal CO2 to be in cardiac arrest? At least
20.
And preferably above 25. So what are the things we can do to try and increase it if it drops below 20?
Better CPR.
Quality of CPR?
Don't hyperventilate.
Don't hyperventilate. If those two don't work,
Bicarb.
consider bicarb. Intubated patient, and you start to see a shark fin develop. What does shark fin tell you? In like a medical situation with a capnography cannula? What does it tell
On
you?
your tube.
Suction your tube in the intubation, exactly. Okay, it's a bronchospasm, but in the intubation patient, it bottlenecks up secretions. Can't usually cause it in the lungs with a cannula, but they can in the tube. Okay, so once you have a shark fin in an intubated patient, suction the tube first. If that clears up the waveform, that was a problem. If it didn't clear up the waveform, then you might move to the whole inline net thing. What are the three things we discussed that could do this? Ross? Bicarb, and then I mentioned briefly the annoying one. Epi may or may not. Okay? So what can we, using what we know about ROSC and its effect on end-tidal CO2, how can we discern whether it's ROSC or something else?
It'll stay.
It stays when you what CPR? Stop CPR versus drops like a rock. Good, you guys got this. Okay, ICP patients. So I had this patient, pretty significant T-bone injury, high rate of speed, probably got T-bone on the driver's side. He was the driver, probably 60 miles an hour, literally a dark, stormy, snowy night in West Denver. And we call for the bird abandons on landing, so we have the patient for about 40 minutes total to get him to the level 1 trauma center. Nasally intubate the patient, good waveform, so I know I'm in the right spot. What am I trying to make sure he stays between? 30 to 35. He's got 2 of Cushing's. He had the chain Stokes and he had the hypertension, but he had normal to slightly tachycardic heart rate. So he was early, so this is the perfect patient. So even as a capnography geek, it was really tough for me to not ventilate this guy. Okay, still intubated him, left the bag on high flow oxygen, because if I would have ventilated him to make myself feel better because he's intubated, what would I have done? So let's say I add 5-6 breaths on there for my sake.
Drop this.
It would have done what to his CO2? Below that 30. And in the PIC study, more than likely, what have I done? I've done more harm than good because I'm detrimental perfusion levels, okay? So in these ICP patients, some of them don't need to be ventilated. Depending on your protocol, you're going to RSI or chemically assist or nasal intubate. But even if you can't do any of that, this all still applies with a cannula and a BVM. Okay, so if you can't do any of that, you can't RSI, you can't, give them ketamine and Versed, you can't nasal intubate, well then get them on a cannula and get them on high flow BVM and make sure you're doing what you can to achieve this range. Okay, so it doesn't have to be ALS level airway intervention. Okay? What about this patient? You need to ventilate him down to?
35.
Okay, and what's your first choice, rate or volume? Rate. Okay, try and keep the volume as normal as possible, but at some point you might have to make a judgment call. What's more important? Same with this patient, right? Ventilate him to 30 to 35. What about this patient? What are they doing to themselves? Yeah, smack them. They're making it way worse than the bleed. This, in my opinion, is the best argument for RSI, not chemical assistance like Versed and ketamine. RSI in a basic pre-hospital, normal, everyday transport crew. Because what this patient really needs is to be paralyzed and you take over their breathing for them. Get those CO2 up so we're not over-constricting. Of course, if this patient's in Cushing's triad, they're going to die anyway, probably, because it's herniation. But sometimes it's a crapshoot. But in a perfect world, if we could take it over, we'd at least do what we could to try and maximize their survival. All right, let's take another quick break. We'll do about 30-35 minutes of cannula stuff, and then I'm going to have to split to the airport. We're going to have to.
20 people in 19